And welcome back to Greater Living after a month off.
Yeah, we've been gone a month. Don and I have been vacationing in the Caribbean for a month and a half.
Not together.
No,
separate islands.
We've been working hard, just haven't been here for
That's
that
how I got
length
this
of time.
tan, working hard.
And in that time, we have a groovy new show open.
Yeah.
We kind of like that. It kind of gets us in the mood for a great conversation today about a little important gland. It's making me clear my throat, like just thinking about it.
And making us thirsty, too.
Yeah, it is. Is that one of the symptoms of something? No. Okay, good. Dr. Ruth Horowitz is here. She is the chief of the Division of Endocrinology and Metabolism at GBMC, and also a partner with Bay West Endocrinology Associates. And we are talking about, drumroll, the thyroid.
Yes, and everybody seems to be talking about
Yes.
it.
Well, it affects a lot of people.
But we should back up and start over again. So if you'd tell us what is the thyroid.
So, nice. Thank you for having me. So the thyroid is a very small gland that lives at the base of your neck. It's sort of shaped like a butterfly, and it produces thyroid hormone. This is a hormone that you should have maintained throughout your entire life. It is not one that goes away like estrogen is programmed to end at a certain time. Thyroid hormone is necessary all your life long, and thyroid hormone is very involved in controlling your metabolism.
And why does it go bad? To use a layman's term.
Sure. The most common reason why people have problems with their thyroid is autoimmune diseases, that their thyroid produces substances, or their body produces substances that attack the thyroid and interfere with it from working properly. And that can cause hypothyroidism. That's the most common thing that we see. You also can get hyperthyroidism, an overactive thyroid, also an immune condition for the most part, where your body produces similar substances that attack the thyroid and then switch it on instead of turning it off. And you can develop nodules within your thyroid also. Most of nodules are benign. 90% of thyroid nodules are benign, but there can be thyroid cancer, and that's due to genetic abnormalities, mutation within the cells that cause this to happen.
So I think in the very broad sense, I think everyone has heard of the thyroid because we are, if not a world, certainly a country obsessed with our weight and diet and metabolism and weight control. And everybody always thinks of the thyroid if they're having an issue with their weight, don't they? But most of the time, that's probably not the culprit.
Yeah, that's actually very true. The symptoms of an underactive thyroid are very nonspecific. If your thyroid's underactive, you can be tired, cold, constipated. You can have difficulty with either weight gain or losing weight. You can have hair loss, trouble with dry skin. But many times a patient has difficulty with their weight and their thyroid levels have been monitored and they're normal. And there's a lot of other things that can cause these symptoms. You don't sleep enough, that can make you tired. You can have skin conditions. You can have poor dietary habits. You could have diabetes predisposition that can make it harder for you to lose weight. So there's lots of things that cross over. So the best thing to do is to see your doctor and have
Simple
some
blood test, right?
Exactly.
Would you say I went online like everybody does with the 12 symptoms of thyroid problems, and there was very little there that wasn't in my life at the moment.
Right. Right.
But,
I mean, most
but the
of
blood
us.
test does.
So Don would like a test as soon as we.
Yes.
I get my
I mean,
I'm tested all the time.
That's a question I get repeatedly as an endocrinologist. They'll see the list and they'll do their checklist and they'll have 10 out of 12 symptoms, and it's worth screening for because it's very, very easy to treat thyroid conditions. But if your thyroid blood work is normal, it's not your thyroid.
So it just leads you to look at some other angle.
Exactly.
Yeah. So what we were just talking about would be hyperthyroidism.
Hypo.
Hypo.
Hypo is low.
Okay.
So the symptoms of an overactive thyroid
would be
which is hyper. Right.
And which is more common than the other?
Hypo.
Okay.
Yeah. So hyperthyroidism is the flip side. You're energetic, you're wound up, you're hot, you have so much energy, you lose weight, your heart is running fast, you may have diarrhea. It's sort of the switch is on. I say to people, it's sort of like being on speed, and you're all wound up. Now, you can also get tired with it because if you run too fast, eventually it's sort of burnout. And sometimes it fuels your appetite, so if you are eating more than you're moving, you still can also gain weight sometimes with an overactive thyroid.
And is that the same thing as Graves' disease?
Graves' disease is one form of hyperthyroidism. That's the autoimmune condition.
And I think we all remember, probably the most famous person that we knew was Barbara Bush, right?
And yes, and George Bush.
Did they?
They both had hyperthyroidism, yes.
Right, with that long list of symptoms for both hyper and hypo, what is the one symptom that says to you, you got to have a blood test?
So for hypothyroidism, the most specific one blood test is the sense of feeling cold. All the other stuff can be anything, but really being cold when you didn't used to be is the one thing that is a little bit more sensitive for hypothyroidism. For hyperthyroidism, it's the losing weight, the jittery, shaky, sweaty. The patients who are hyperthyroid actually have a very specific look. Sometimes they actually literally vibrate. I can have a patient come in and you touch them and you can feel it because they're so wound up.
And what says surgery and what says drug treatment?
The majority of hyperthyroidism can be treated with medication, or for an underactive thyroid, it's oral medication. For hyperthyroidism, there are oral medications that can slow the thyroid down, and in certain circumstances, somebody who has an overactive gland can be treated with oral medications for a while and then go into a remission. It can slow itself down. It has a risk of relapsing, but there are certain patients that actually can slow down and be normal. If you have persistent hyperthyroidism or very severe hyperthyroidism, we can treat you with something called radioactive iodine, which is a capsule. It sounds scary, but it's a capsule of a very small amount of radioactive iodine, and iodine is what the thyroid uses to make hormone out of. You swallow it, it's taken up into the thyroid, and it stops the thyroid from working. Surgery is indicated in somebody who might not be able to do that, or I've had an occasional patient who's gotten radioactive iodine and it doesn't work and they need to have surgery. Usually surgery is more indicated for somebody who has a thyroid nodule or just a very, very large gland that might be causing compressive symptoms.
So we have so many questions about this topic. I mean, a lot of it has come in over Facebook. Some are happening right now with our studio audience. And so and most of it is about hypo or hyperthyroidism. Sure. And I know we're going to talk about the cancer aspect as well, but let's kind of stick with this. And maybe we should get to our questions so we can get everybody in. You want me to start with Charles?
Sure,
okay. So Charles writes us, I was told that a blood test suggested hyperthyroidism. A more complete blood test showed that I did not have hyperthyroidism or Graves' disease. Again, that's just one form of it, right? However, I was told that the marker is there for the hyperthyroidism. Am I in any danger?
So, what I'm assuming the person had was some abnormal blood work to start with. When we do thyroid tests, there are a variety of different tests that we do. We actually measure the amount of hormone that's coming from the gland. That circulates in your system and feeds back to the brain, to the pituitary gland. The pituitary puts out a signal called thyroid stimulating hormone that stimulates the thyroid to make hormone. If you're making too much, the stimulator goes down. And if you're not making enough, the stimulator goes up, sort of like the thermostat regulating the heat in your system. We also can measure antibodies. The antibodies are the substances that I was referring to that switch the thyroid on or off inappropriately. And these antibodies are targeted against the thyroid, so you can measure these antibodies. The presence of the antibodies don't necessarily correlate with the function. So you can have normal thyroid hormone levels and positive antibodies. You can have abnormal thyroid function and not have any antibodies at all, because not all thyroid disease is from the antibodies. So in this particular patient situation, I have a suspicion that his thyroid function was normal, but he had these antibodies. And that indicates a predisposition that they might at some point develop a thyroid condition, and they need to be monitored.
Okay, this question is from Vickery. Same question. All thyroid disease sufferers have Hashimoto's. The question is there any way a thyroid can ever be reactivated once diagnosed?
So Hashimoto's is one name for autoimmune thyroid disease. I like descriptions rather than names. So Hashimoto's was named after someone, such as like Graves' disease was named after an endocrinologist. Hashimoto's is the underactive form of autoimmune thyroid disease. So when the patient's question is, if I've developed, I assume, an underactive thyroid, will it ever come back? Generally speaking, no. If you've destroyed enough of your thyroid gland that it's not working, it doesn't tend to...
You can't rejuvenate
it. Now, sometimes there's a question I know that's going to come later on because I got a preview. Sometimes these antibodies can sort of switch their nature. They can be blocking antibodies, and then you can develop stimulatory antibodies. So I have had some patients go back and forth where they've had an underactive thyroid and then all of a sudden develop an overactive thyroid. That happens occasionally. And sometimes if
Does healthier living help that to happen, or you can't control it?
You can't control it. It's totally out of your control. And sometimes if you have sort of a lumpy thyroid that's not working well, you can form a nodule within your thyroid that can become overactive. And you might be on thyroid replacement and then start all of a sudden developing an overactive nodule and then have high levels. But that's not common generally.
Gotcha. Okay.
So when we were talking about the healthier living, Kathy writes, any diet considerations for hypothyroidism?
No. There's nothing you can consume to fix your thyroid. Some forms of thyroid dysfunction in certain parts of the world are due to iodine deficiency. So there are some people that don't get enough iodine, they develop a goiter and an underactive thyroid, but in the United States that's not a common problem because all of our salt is iodinated. Yeah. And even if you use, say, sea salt, which is an iodinated, all of our food has regular salt in it. If you buy, one bag of potato chips, you get plenty of iodinated salt in that. The thing that we should avoid actually is taking iodine. Some people think that iodine will help their thyroid work better, but iodine actually can either block the release of thyroid hormone and make you underactive, or it can actually stimulate thyroid hormone production. So in some patients, depending on what their underlying thyroid problems are, it can be very, very dangerous. So I suggest to people don't load on iodine pills or kelp pills or other things like that. And other than that, there's really nothing you can take or eat to make your thyroid work better.
This question is, I'm hypothyroid. My singing voice seems to vibrate more these days and getting lower. Is that part of being hypothyroid?
So,
been on Synthroid medication for over 20 years, he or she says.
Yeah. So one of the signs of an underactive thyroid is hoarseness. You can get sort of thickening of the vocal cords, and that might be a sign that the thyroid levels are not replaced well enough. Other than that, it shouldn't have any effect, unless also the person has a very large thyroid. The nerves that control your vocal cords live right underneath the thyroid, and if your thyroid is very large, it could press on that nerve and cause some vocal discomfort or vocal changes. So it's worth perhaps seeing an ear, nose, and throat specialist to have the vocal cords looked at to make sure there's no issues, or perhaps seeing your doctor to have your thyroid looked at.
A quick follow-up to that, if I may.
Yeah, no.
We've read that when you are having surgery or have had surgery, that your voice could be affected afterwards. Is that permanent, or is that just
The majority of the time is not permanent. In the hands of a well-trained endocrine surgeon like Dr. Turner, who was just here, they know how to identify those nerves and avoid them. If you are going to have thyroid surgery, you really don't want someone who does this on occasion, because you don't want a permanent injury to the vocal cord nerve, the recurrent laryngeal nerve. If you cut that nerve, that's a permanent problem. If sometimes the thyroid is very large and it causes some traction or some swelling of the nerve, and that's usually a temporary thing, and with some voice training or time, that will go away.
It's reversible. We have a question from our audience.
We have a lot of questions from our audience. A lot of them.
Throw a couple our way.
A lot of them have to do with medication. So, are there certain medications that can either be replaced by natural supplements, such as melatonin, and other supplements, and can you take supplements with thyroid medication?
Okay, so thyroid hormone should always be taken by itself first thing in the morning on an empty stomach. And you shouldn't consume it with your other pills at the same time. Specifically, the worst offenders are calcium and iron, or multivitamins can interfere with the absorption of thyroid hormone, and that can affect your blood levels. So you want to take your thyroid hormone all the time by itself. If you take things later in the day, there shouldn't be any interaction with that. So no for that. Will any supplements, I think the question was, do any supplements help the thyroid? And not really, no. There's nothing, and I would caution people to avoid things that are called thyroid support or any of those natural supplements.
What about metabolism support? There's a ton.
Yeah, I'm not a real fan of those, personally. I think that the best way to improve your metabolism, I'm old school, diet and exercise.
Yeah, we don't want to hear all that.
So that,
Sorry,
that
nobody wants to hear.
That includes herbals? I mean, so many people are into herbals.
No, there's no herbal supplements. I actually had a patient unfortunately, she had mild underactive thyroid and really was trying to avoid taking thyroid hormone. So she was seeing a physician who recommended some supplements, and that contained a lot of iodine in it. And because he told her that it's iodine that causes the problem. And unfortunately, the patient took the iodine supplements. And when I saw her, I rechecked her numbers, and her numbers were much, much worse because iodine can block hormone release, and she made her condition even worse by taking the supplements. So you have to be very cautious about some of these natural supplements. They really can be
Well,
very
you're hearing a lot.
dangerous.
I mean, even bone broth is becoming.
Yeah.
You don't believe in it?
No, that's not. Again,
I don't
I'm
like the
not.
sound of it.
I would put out. I'm not. There are certain supplements I think are very beneficial, but I am not a person.
Maybe for other things, but not for the thyroid.
Not for the thyroid. Yeah.
Okay. All right, we'll get back with you. I know you've got that big question mark up, but let's take another one from our Facebook page in case folks are tuning in right now and they want to hear their questions. We got that one. So how about, is it, and you don't have to leave your name, we should mention too. A lot of people have asked questions and have not left their name, and that's cool. We get the privacy angle of all of this, so that's fine too. So here's the question. Is it possible to be diagnosed with hyperthyroid and then later as hypothyroid? If so, what causes that to happen?
Right. So, yes, I referred to this earlier. So what causes many of these thyroid conditions are antibodies. Antibodies usually fight infection. They're against something foreign. But there's a whole host of autoimmune diseases where the body produces antibodies that target itself. And in thyroid, the antibodies bind to the surface of the thyroid to where the thyroid stimulating hormone, which is the pituitary signal, normally would bind to and will either block it or turn it on, sort of a lock and key. Either blocks the lock or turns the lock on. And that will make the thyroid either over or underactive. And sometimes these antibodies can change their nature or be stimulatory at one point and blocking at the other. So yes, you can see this. It's not the most common situation, but you do definitely see that.
But if it can switch from hyper to hypo or back and forth, does it ever switch to just being normal? Or once you have one of these issues, you're not ever going to be quite able to...
No, I do have some patients that are hyperthyroid that sometimes the antibodies dissipate over time. But with hypothyroidism, generally speaking, it's a destructive process, and so it often will permanently leave the person with an underactive thyroid.
It seems these days we often learn of drugs by one company's brand name, which I think is Synthroid, right? One of our questions is, generally, how effective is Synthroid in reducing very high TSH levels? And what are the chances that I would see better results on a different medication?
Sure. There are several brands of thyroid hormone that are brands, and then the generic is levothyroxine for T4, which would be the equivalent. And the Endocrine Society, which is one of the bodies that govern how we treat patients, do recommend that we use brand thyroid hormone. Levoxyl and Synthroid are two of the most common brands. There's also Unithroid, which is another one. And that's because we know that the thyroid hormone in that pill is going to be the same from lot to lot to lot. So if you're taking 100 micrograms of Synthroid, every time you know you're getting 100 micrograms. Levothyroxine, which is generic, can be more or less potent by about 12%. And the FDA feels that that's equivalent. That's considered bioequivalent. And as endocrinologists, we know that 12% would be the next higher dose if you're taking 100, because the next dose is 112. Or it might be the next lower dose, which is 88. So we like the brand for consistency so that we know that the patient is always getting the same amount and they're more likely to have very steady blood levels.
Is there one you always recommend, or does it depend on the patient?
It depends on the patient. What we're having trouble with these days as a prescriber is that many of the insurance companies won't pay for brand anymore.
And that was my next question to you, because there are a lot of people on generics, and they're willing to do that and risk the differentiation and the way it's made up.
Right.
Because it's so much less expensive, and that's what they can afford.
Absolutely. You can get generic thyroid hormone for $4, whereas a brand might be $25 or $30 a month. And for many patients, that's just really out of their price range. If you are using a generic and you are using the same generic manufacturer time after time, you should be able to get consistent results. But sometimes the pharmacy will use one generic and then get another distributor and get another one. So if you see that you're manufacturer is changing, you should get your labs repeated about 6 weeks after you switch from one generic to another generic.
To make sure it's
just to make
effective.
sure it's effective. Which sort of goes, it ends up costing the
Right.
insurance company more money because you're getting more blood work instead of having the consistent labs. So
If the
it's
insurance company's paying for it.
Right. It's an argument we've made in our position statement to the pharmaceutical companies all the time. It doesn't.
But healthcare is so perfect in the way it's so surprising. Okay, can thyroid issues cause acne? How would I go about getting my thyroid checked and diagnosed by a doctor? What tests are needed? Couple questions.
Sure. Thyroid isn't generally associated with acne. There are a lot of other hormones that can be associated with acne formation. If you're going to have your levels checked, the two tests that I do most commonly is a TSH, thyroid stimulating hormone, which is the pituitary signal. I call that the internal thermostat. That one gives me the best idea if that particular person's body is happy with the level of hormone that they're producing. And I also check a free T4, which is one of the hormones that the thyroid produces. You also can check a total T3, which is the other hormone the thyroid produces. And in certain circumstances, that's also really valuable to check also.
Okay. This question is about something we hear from other thyroid sufferers when we do suffer. I heard that in order to properly test thyroid hormones, you need to test at certain times of the day. Is that true? And can you explain the best way to get accurate results?
Yeah, thyroid hormones are really flat. They do not have what's called a diurnal variation. There are some hormones that you produce more in the morning and less in the evening, like cortisol or testosterone. They have a very up and down kind of thing. Thyroid's not that way. Your thyroid levels are pretty flat all day long, and especially if you're on thyroid hormone, very, very flat. So it doesn't really matter whether you're fasting. It doesn't matter morning, night, or afternoon. It'll be very even all through the day.
But fasting is in there.
No, you don't need to fast.
Oh, okay.
No, for other hormones you do.
Gotcha. Okay.
Not for thyroid. You do not have to fast. And you can take your medicine, if you're taking T4, levothyroxine, Synthroid, Levoxyl, you can take your medicine in the morning and still get your blood work done because it doesn't cause a spike in your levels. It's a very flat, slow release hormone.
Do you ever see patients who come into your office thinking they have something and you just take one look at them and you're like, oh, wow, yeah, we need to test you.
That's Graves' disease is one of those. You
can just spot it.
Oh, yeah. So Graves' disease, which is the hyperthyroid form of thyroid disease, can sometimes be associated with a certain set of eye findings. When your thyroid is overactive, there are two things that can happen. Your eyelids sort of are a muscle that responds to thyroid hormone and actually get a little tight and retracted, and you can also develop inflammation of the muscles of the eye that actually make the eye sort of move forward in the orbit, and you get what's called a stare, which is sort of like a wide open look. Sometimes it's just the lids retracted, but sometimes the eyeballs really actually are forward moving, and you can see that in someone's face. You also can sometimes see their large thyroid if they have a very big thyroid from the hyperthyroidism. They may have lost weight and look kind of gaunt. They develop a tremor. They may have a very rapid heart rate. And patients with Graves' disease often have the smoothest skin that you have ever felt in your entire life. It's very, very unique, and it feels, we call it baby butt. It feels like the behind of a baby. It's the softest thing.
Sounds wonderful.
Yeah, it's very, very nice. So
not worth it, but wonderful.
Yeah. So, and also the other on physical exam, their reflexes, when you check their reflexes, are very, very brisk. They're very fast. So.
A follow-up about the eyes. I just saw a movie with Peter Lorre in it.
It's sort of like that.
Yeah, I mean, I was
Could
going
he
to
have
say,
had that?
does he have problems? Yeah.
Don't know.
Did he?
He could, yeah. But that sort of, that bulge-eyed stare is very typical.
If it goes undiagnosed, what can happen?
You can have difficulty with moving your eyeballs. I've had a number of patients who have actual restricted eye movements because the eye muscles get so large, the eye doesn't move properly. So you can develop double vision, headaches, trouble seeing, and you have to be very careful about how you treat those patients because certain things can actually make that worse when you treat the hyperthyroidism. In very severe cases, patients sometimes might need surgery. Sometimes radiation to the orbits can fix the eye problem. So it can be serious.
Okay, another question is my only option for an enlarged thyroid pills. I think you kind of said that.
Yeah, I mean, if you have an underactive thyroid and a large thyroid, it may get smaller if you go on medication. Sometimes the thyroid is enlarged and the function is normal, and there's putting people on thyroid replacement when they have normal function won't likely make their thyroid any smaller. So in certain circumstances, when you have a very large thyroid, surgery is really what's indicated to treat it.
All right, our audience is on the edge of their seats, so we want to get some questions from the audience.
So we've got a live question.
Good. Got a
I
live
hope
answer.
I hope this question isn't naive. You made a comment several times about the relationship between the body's production of antibodies and thyroid normal function or non-normal function. Would it be true that if a person has more infections in which antibodies are being generated to fight the disease, any kind of infection where you take an antibiotic or get sick, if you get sick more often, are you more likely to have a problem with thyroid problems?
So the antibodies that you form to fight a normal infection have nothing specifically to do with the antibodies for the thyroid. However, you can develop something called a thyroiditis after a viral illness. And a thyroiditis is an inflammation of the thyroid gland where the thyroid gets inflamed and then leaks thyroid hormone out, sort of like a balloon with a hole in it. And that can cause a form of hyperthyroidism. And that's usually followed by a period of an underactive thyroid when the thyroid is sort of deflated and has lost all its hormone. And then generally that's followed by normalization. And that is often after an infection, but it's not because of the antibodies. It's actually due to the virus in the thyroid itself.
Is it common?
We see this.
Okay. All right.
We see it also. It's you can see this specifically after a woman has a baby, and it's called a postpartum thyroiditis. And generally, that presents around the time where the woman is getting their first visit, their 6-week visit, and they've lost their weight very quickly, and they're all happy because they've lost all this weight, and it turns out they have a thyroiditis. So usually, though, with a thyroiditis, if you wait, it goes away. So they'll go through the hyper, then the hypo. It's about 6 weeks.
So the hormones kind of settle down.
They settle down. It's about 6 weeks to 3 months of hyper, hypo, and then normalization. Unfortunately, if you have such a bad thyroiditis that you damage so much of your thyroid, you may end up not recovering, and you could be left with a permanent hypothyroidism. And sometimes thyroiditis can recur. There are some patients who get it repeatedly, and then you'd have to decide about doing something like surgery if they keep getting bouts of thyroiditis. It becomes very inconvenient.
Another one from the audience?
Yes. Are soy, gluten, and other food products contraindicated and when you're taking Synthroid? And also, is it contraindicated to take melatonin when you have Synthroid, when taking Synthroid?
Sure. No problem with any of those. If you wanted soy, if you wanted gluten, you could take it. Melatonin shouldn't have any interaction with thyroid hormone. If you wanted to avoid them for whatever other reasons you had to, let's say some people are gluten sensitive and that causes bowel problems and you were avoiding it, that wouldn't affect the thyroid either way.
What if you're taking thyroid medication and you're taking hormone replacement, or you're starting to work with your hormones on another level? So
there is. That's a sort of a little bit of a complicated answer.
I'm sure.
Yeah. So
hormones are complicated, right?
So the taking of estrogen, say, as your hormone itself does not interfere with thyroid hormone, but estrogen will change a substance in your blood called thyroid binding globulin, and binding globulin is the little, I just call it the little boat that thyroid sort of moves around in your bloodstream on, and the binding globulin on estrogen rises. Now, your total hormone level, it gets, like I said, complicated. Total hormone goes up a little bit, but your body's really smart, and it knows how to offload just the right amount of thyroid hormone to do its job. That's the free hormone. So your free hormone will stay steady because your body knows how to regulate that, but your total hormone may go up a little bit. And if your doctor, and this is not an uncommon consultation I get, your doctor checks your total hormone and it's high, they may think you're on too much medicine. But if they check the free, it will be right where it needs to be. So the hormone doesn't really affect the amount of medication you need. It will change the labs a little bit.
Okay.
And you just have to know how to interpret it and get the right test from your doctor.
Another question?
Okay, so we have quite a few questions about other medications. Are there certain medications or other medical treatments, such as radiation treatments, likely to cause thyroid issues?
There are some forms of radiation that can actually very much disrupt the thyroid. We see this in patients who've had certain malignancies that get head and neck radiation or mantle radiation. With patients like Hodgkin's lymphoma, they'll get radiation to
Or
the
esophageal cancer,
yeah,
maybe.
well, many patients with esophageal cancer often end up with a very radical neck surgery, or as people with head and neck cancer may actually have their thyroid removed in the whole process, or radiation to the neck. And then that may, over time, lead to a higher risk of developing an underactive thyroid.
It's time for me to bring up my grandmother. She died in the 1970s,
Okay.
but she had thyroid problems. And she worried all the time I knew her about developing a goiter. And she would point to other people who had goiters and stuff like that. I don't see goiters around anymore.
Right.
What is it? And it's tied into the thyroid, obviously.
Sure. Well, a goiter is just another term for an enlarged thyroid. Those goiters that we used to see, those sort of endemic goiters, the ones that are huge, we don't see that often anymore for two reasons. One is we now have sufficient iodine in our system to prevent that, and most people don't let it go that far. You know, somebody will go to their doctor when their thyroid gets an iota bigger and say,
Yeah.
you know, and they get treated, evaluated fairly quickly. I have had some patients that do have very, very large thyroids still, and you know, oftentimes patients are not symptomatic. They can have an extremely large thyroid or a very large lobe and not even be aware of it. It's because it's just sort of sitting there and growing out. And oftentimes somebody else will say, hey, you know, what is that? And the person doesn't even realize it.
Wow.
That's incredible. We do want to get more from our audience, but also we have a whole another sheet of questions from Facebook. You're very popular.
It's a lively topic.
We haven't done this one yet, have we? Here's one. My thyroid was recently tested with a blood test, and the results were within acceptable margins. I was wondering if it's still possible that I have a thyroid issue. I am overweight by about 85 pounds, and nothing I do helps me lose weight. Okay, I can relate. Diet doesn't help. Exercise doesn't help. Nothing. I feel like I have other criteria that meets an underactive thyroid, but my blood test was fine, and my maternal grandmother had thyroid cancer twice. Thoughts?
Okay, so this gets back to the unfortunate situation that thyroid symptoms are very nonspecific, and there's a lot of things that also cause similar symptoms. So, unfortunately, if the thyroid levels are really in the normal range, it's probably not the thyroid that's causing the problem. There have been studies where they put people on thyroid hormone when they had normal levels, and it doesn't help lose weight at all. And actually, being on an excessive amount of thyroid hormone can be dangerous because it makes you hyperthyroid. And overtreatment with thyroid hormone can cause cardiac arrhythmias and can accelerate bone loss and lead to osteoporosis. So you don't want to put someone on thyroid hormone that really doesn't need it. Thyroid cancer is asymptomatic in 99% of people. Most patients do not know that they have thyroid cancer. They don't have any
That's
symptoms.
frightening.
Yeah, it's because it's within the nodule of the thyroid. And if you don't have abnormal function, if you have a thyroid cancer that's within a thyroid, the rest of your thyroid may work perfectly fine and give you no symptoms at all. So having your doctor do a regular examination of your neck. A person who picks up a lot of thyroid is gynecologists, because they feel women's neck all the time, and women tend to have more thyroid disease than men because women tend to have more autoimmune disease than men. And so oftentimes we just don't even know it's there for thyroid cancer. But luckily, thyroid cancer is very slow growing, and it has a very low mortality rate. So, we're pretty lucky about that.
Okay, this one's sort of connected to that. I was diagnosed with hypothyroidism last year. I also had a lump on the side of my neck, didn't give it much thought, until I went to see an endocrinologist who did a biopsy and told me that it was thyroid cancer, stage 4. I'm now on a chemo pill, but my question is it treatable?
That's a difficult question to answer in this situation. Thyroid cancer generally has an extremely low mortality rate. Even advanced cancer has a very low mortality rate. And usually it is completely treatable with thyroidectomy. remove the whole thyroid. Before someone has surgery, as endocrinologists, we often do an ultrasound of the neck looking to see if they have any lymph nodes in their neck that might adjust the way we do surgery. But just a thyroidectomy is usually all that is necessary. Sometimes in certain patients, we treat them with something called radioactive iodine. The same thing that we use to treat hyperthyroidism also can destroy any microscopic disease someone has left from thyroid cancer, and that's generally all one needs for treatment of thyroid cancer. Occasionally, in some patients that have more advanced disease that have spread locally, and thyroid cancer tends to spread.
I was going to ask you that. It jumps to the nodes? Is that where it
Yes, to the lymph nodes.
Okay.
So
Yes.
you can have it invading into the local soft tissue and then into the lymph nodes. In much less frequent situations, you can have it spread to the lung is the next place that we tend to see it. I've seen some distant spread also in very, very advanced cancer. But even in that situation, very often with chemotherapy, there's several different forms of oral chemotherapy that we're now using for more advanced disease. Patients do very, very well.
So since
Stage 4 isn't as serious as it is in other forms of cancer?
Correct. If you have a stage 4 lung cancer, the prognosis may be much, much worse than with thyroid cancer.
So since we're talking about the cancer now, and she didn't catch it until she was stage 4, it sounds like. What are the signs of thyroid cancer?
There aren't any. Unfortunately,
Well, there has to at some point be a sign, right?
not usually.
It's going to be the doctor feeling it?
Correct. So occasionally you might have a patient that presents with a lymph node that's enlarged, and that may be a sort of more advanced situation, but that's not the common situation. Very commonly, what will happen is your doctor will do an examination, and they'll feel that you have an abnormality in your thyroid, and your thyroid lives right above your sternal notch, right here, right below the Adam's apple in men. They are often palpable. You can feel these nodules. And then your physician will order an ultrasound to evaluate it. And there are certain findings that we look for on an ultrasound that would increase our concern that a nodule might be a thyroid cancer. So they've done a variety of studies saying these are the things that nodule that cancer are more likely to have. And if you see those things, and if the nodule is of a substantial size, the endocrinologist generally, or sometimes a radiologist, will do a fine needle aspiration, which is a fancy name for a biopsy, of the nodule. And a biopsy is something that we do in our office. It's a very simple procedure. We do them all the time. We do them with ultrasound assistance, so we can identify the nodule, and we take a very small needle, smaller than what we use to draw blood with.
Do you use local?
Yeah, I do.
Yeah.
Most people do. A little bit of lidocaine. And you put that gently into the nodule with the ultrasound guiding you, and you remove a little sample of tissue. And when I do a biopsy, I do that three samples so that we get enough tissue, and we send that off to the pathologist. And there are 4 results that we can get. Benign, that's a good one. Cancer, that's pretty clear. Then unsatisfactory. Sometimes we try really hard. We get tissue out and goes to pathology, and there's not enough of the right kinds of cells for the pathologist to make a determination. And sometimes we get a biopsy back that's called either inconclusive or suspicious or indeterminate. It sort of depends on the pathology and what exactly they're seeing. And these are nodules that look a little funny but aren't clearly cancer. So for benign nodules, generally we watch them. We might repeat an ultrasound in the future, and if the nodule grows, we might repeat a biopsy in the future. And we watch also to look to make sure that the person's not forming other nodules that might be of concern. If it's unsatisfactory, we usually wait a few months and repeat the biopsy, try again, and we're usually successful a second time. Cancer, thyroid cancer, should come out. And there's a changing recommendation these days about the extent of surgery. In the past, we were doing total thyroidectomies on everyone, and there's some changing recommendations that we consider having half the thyroid removed. And actually, it's very interesting. This is a very controversial issue. There's some recommendations that even somebody has a small thyroid cancer, less than a centimeter that we know of, we should actually leave it in there because it's that...
Because the risk of the surgery is greater than leaving the...
Well, no, because the thyroid cancer is not likely to ever harm you. So it's okay to leave it. Now, we had this discussion
If I was a
earlier.
patient, could I say take it out?
Yes, you can. So, unfortunately, so the debate always goes is like, well, if you're not supposed to remove a cancer that's less than a centimeter, why would you be biopsying it in the first place? So there's a lot of controversy about that still. And then the indeterminate biopsies, there are some forms of thyroid nodules where the benign version and the cancerous version are very difficult to tell on a biopsy. And now we have some very sensitive genetic tests that we can send off on the biopsy specimen that'll help us tease out which ones are more likely to be malignant and which ones are not. 80% of the ones that are indeterminate are actually benign. And we used to just send everybody off to surgery because we couldn't tell. And now we can save surgery for many, many patients, and we can just watch those nodules carefully.
Just a clarification for me, the biopsy is done from outside or is it done down the throat?
No, it's through the neck.
Okay.
Yeah, you lay on a table, clean the skin with a little alcohol, and just take a little needle and put it in. I can tell you, based on having performed them and having had a little personal history, a little breast biopsy in my past, breast biopsies are infinitely worse than what we do with a fine needle biopsy.
Oh, that's
of a
good
thyroid.
perspective.
Yes. So,
I can say that about prostate.
yeah, I can tell you that a thyroid biopsy is much better than a prostate biopsy by 1,000,000%.
And while you're talking about the breast, of
Although-
course, not that we're going down to the breast, but we're back up
Yeah.
to the neck, but self-examination. So you can, if a doctor can feel the thyroid, why can't people at home?
Find it. Sometimes they
Yeah.
do. You know, I have had patients come to see me that they're saying, "Oh, I'm putting lotion on and I'm doing this," and all of a sudden I'm like, you know, what is this? And so patients sometimes can feel, but the thyroid sort of sits underneath the strap muscles of the neck. It's sort of tucked in there a little bit. So sometimes you got to sort of dig in there a little bit. And if you've ever
So you don't want to encourage that?
No. I mean, people want to play with themselves, they can, but
Play with your thyroid,
Yeah.
everyone.
but I've had patients where I can feel it, and I'll say, "Okay, give me your finger," and I'll put their finger right on the spot, and they're like, "Oh, yes, I feel it," and they can tell. But very often you really have to be somewhat aggressive in the exam. And when my patients come to see me, I usually preamble it with, "Now I'm going to choke you," or strangle you is sort of the terms I do to warn them before I do their exam, because it's kind of an uncomfortable exam, and you definitely can do a little coughing because you really got to sort of dig
Press
in there
in
a little
there.
bit. Yeah.
All right, more questions. Do we get to that one?
I think she's
Yes.
got-
Oh, we're going to take the audience? Okay.
Still more audience questions. So if a person had radiation or cancer treatments up to 70 years ago, does that still cause thyroid cancer and other thyroid problems?
Yeah. It's sort of, you should have your thyroid examined regularly, and you should also have periodic blood work done. The other form of radiation that can cause problems with thyroid nodules is there used to be this done. This is not done anymore. But in the past, people had radiation done for acne. They also had it done for adenoids and tonsils. Sometimes people had radium treatments in their nose as a child. My mother had the acne stuff done, and she ended up with hypothyroidism. If you have a thyroid nodule and you've had that kind of radiation exposure, that can slightly increase your risk of thyroid cancer by about 5 to 10%. So, and that's done, when you were a child, and now as an adult, when you're 50 or 60, that might be a problem. The other form of radiation that definitely causes problems is some of the accidents that we've seen in, say, Chernobyl or Fukushima. The nuclear accidents were absolutely associated with thyroid cancer, increased risk in those regions. And in Baltimore, there's a large Russian population that lived in that area during the time of Chernobyl, and I still have patients that come to me, and
Wow.
I'm evaluating them for thyroid nodules.
Do you have a general recommendation? I know we should go for a yearly well visit. People don't always do that, of course, but after a certain age, do you recommend they do that, if not for anything else, to check the thyroid?
People should have an exam done regularly.
Once a year?
Once a year.
Okay.
Yeah.
As part of a physical, do they test for it when they do the blood test?
Some doctors do. It is not a standard that you have to have it done annually, but you should have it done periodically, especially if you also have a family history of thyroid disease, or if you have high cholesterol. Sometimes an underactive thyroid can cause your cholesterol to be higher, so it's worth checking as a screening test at TSH, a thyroid stimulating hormone.
More questions from the audience? We want to get to those?
So we have a question from John. He asked, does thyroid function affect blood sugar? My wife has been hypothyroid for a long time and has been treated with meds, but she's now experiencing low blood sugar and associated effects.
Should not be. There's not a specific association. I think that if you're hyperthyroid and your metabolism is really revved up, maybe, but there's not a direct correlation between those.
Are hormones more difficult to stabilize in women? Then, in other words, is that a loaded question?
Yeah, just sort of trying to figure that one out.
You know what I mean?
Yeah.
It just seems more complicated. You know, women are dealing with other kinds of hormones,
Sure.
right? And that's a complicated concoction there.
Right.
But the thyroid is more cut and dry, I get the sense.
Sure. So there are lots of hormones in your system. There are the reproductive ones that you're describing, which are the estrogen and progesterone, and menopause. That's a whole nother topic. Thyroid hormone is usually, for the most part, very easy to replace.
Okay.
It's as long as you take your medication properly. And you don't take it with other things that would interfere with you absorbing it. I have seen a fair number of patients that come to see me that say they can't regulate my numbers. It goes up, it goes down, it goes up, it goes down. They're always changing my dose. I tend to just make sure first that the patient's taking it on an empty stomach with no other medicines. That nothing new has been added in. You might have a patient that's been taking a regular dose for a while, and all of a sudden the numbers go off, and they've been put on something for acid, and so they're not absorbing their medicine anymore because they're now on, say, Protonix or Prilosec, and they're not breaking down the pill as well. Or they started taking calcium because they now have been diagnosed with osteoporosis, and they take their calcium with their thyroid all in the morning, and their levels drop. That can make it harder. Sometimes also blood work fluctuates a little bit, and people sort of get very focused on subtle changes in the thyroid levels. And if somebody's been on a steady dose of medicine for a while and their levels go out of whack for whatever reason, I will wait, make sure they're taking it right, retest in another 6 weeks, and very often it'll come right back down. And patients may say, oh yeah, I occasionally miss a dose. They might say, oh, maybe once a week I miss a pill. For endocrine, for thyroid, that's changing your dose entirely. Whoa. That's as if you are going to a significantly lower dose.
So you have to really stick with it.
You have to take it every day, and you can't miss. And I occasionally tell my patients, if you miss it one day, take it later in the day. Even if it's not fasting, it's better to get it in than miss it. Or sometimes take 2 the next day. Nothing terrible will happen if you take both of them together the next day.
All right.
One more for the audience, or no? Yeah? Okay.
Yep.
Thank you.
We're shutting you off for right now.
Yeah.
Thank you, Dr. Ruth Horowitz.
Oh, sure.
Yes,
From
thank you so much.
Sure.
We could have talked for another hour, which is always the
That went
case
very quickly.
when you come to visit us. And we should mention, too, we didn't get to all the questions from our Facebook crowd. So I know GBMC, and I know you're available, and there are always people available on Facebook, on social media, to answer the questions that you may have and that you didn't hear from this converstion. So
Absolutely.
thanks so much.
Yeah, thank you.
So
Thank
great
you.
to see you again.
Thank you.
And don't leave
Yeah,
it
you
yet.
can clap. Go ahead. But as
You're watching
always,
online, don't
it is
leave
so
yet.
great when you can talk with someone who's been there. So we have the experts, obviously, from GBMC, but it's so wonderful of some of the patients to come up and talk about what they've actually been through. And
Hello.
And so we have one right here. Thank you so much for being with us, Danielle.
You're welcome.
Curcio.
Yes.
Good.
Yes.
Thank you.
You're welcome.
So is Dr. Horowitz your doctor?
Yes, and Dr. Turner performed my surgery.
Oh,
Very good.
all right,
So
great.
you obviously had the surgery.
Yes, yes.
Can you tell us about your
Sure.
case in brief?
So I have quite a story. So I was diagnosed with type 1 diabetes at 18 years ago. So I've had the test every year. I had my thyroid as part of the workup tested. It was always normal, so nothing to be alarmed of. Then I had a stroke 9 years ago. And when they were doing the dye test to find the clot and everything, they found a small nodule. So of course we biopsied it. It was benign. It was fine. But then over the years, Dr. Horowitz always biopsied it every year or two. Did my thyroid levels. Everything was fine. And then I had my daughter almost 4 years ago. And hormones, it grew a lot. But again, Dr. Horowitz said nothing to be alarmed at. It's your hormones. Let's see after you have your daughter if it goes back down. Went back down a little bit, but then it started to grow progressively more. So had no symptoms at all. No symptoms. I couldn't feel it, just as Dr. Horowitz just said. I couldn't feel it, but she'd take my finger and go, oh, do you feel it now? And I did. So the last biopsy came back indeterminate. So Dr. Horowitz had said, look, it's getting big. It's starting to push your larynx over, your trachea over. And we're starting to get a little fearful that when we biopsy it, maybe we're not getting quite enough of it. So it's better just to take it out. So it's been 6 weeks Monday that I went to Dr. Turner. So he took the right
But
side
you're
out.
6 weeks out from
Yes,
surgery?
Yes,
That's
you can
incredible.
barely see the
You can-
scar.
You cannot?
No, you
Barely see
cannot.
it. Yeah. So I had it at GBMC. He did a hemithyroidectomy on the right side. So Monday I went back to get my blood test. I haven't got the results yet to see if the left side is kicked in, and I won't need, hopefully, any kind of medication or anything. But that's not back yet, so we don't know yet. But same thing. It was outpatient. I had the surgery. It was about 6 hours. I had to wait and really wait to look to see if anything's swelling or any kind of complications. I was fine. I could have stayed, but like I said, I have a 4-year-old home, so I wanted to go home. And I've really had no complications, knock on wood, since the surgery 6 weeks ago.
No raspiness or
Nope.
soreness? Or
Nope. And again, I can't say enough. It's all your team. You have to make sure you have. I've been with Dr. Horowitz probably 8 years now, and she is awesome. And Dr. Turner, he's a skilled surgeon, so I've had no after effects. No, my throat was a little sore, maybe like a day or two after, but that was it. I was back to work in a week and driving within a week and
you're
full
a person,
activity.
obviously, who's used to managing your health.
Yes.
You've had some scares,
Yep.
and you've been dealing with a lot of
Yes.
things. And so
Yeah.
it almost sounds like in the scheme of things, this was the least
Yeah.
difficult.
I had a little bit of anxiety leading up to the surgery.
Sure.
Who doesn't? But then after it, I kind of woke up and I'm like, oh, is that it? And then, a few days later, like Dr. Turner said, I felt fine. Neck was a little bit stiff, but that was it. And again, it came back, the pathology came back that it was 0.2 millimeters of cancer. So I'm kind of like, if it's a centimeter,
Good,
I want
yeah.
that out.
Exactly. I'm
So
with you on that.
if people think, oh, I don't want the scar, I don't want to do it. I say do it because, what could happen could be much worse. So I was glad to get it out.
So talk about now, and I don't know if you're in full management mode yet, but I guess you are, right?
Yeah.
How you're managing the meds, how that's working for you, how they figured out what you needed.
Yep. I haven't yet because I had to wait 6 weeks till after the surgery. So when the blood work comes back, we'll determine with Dr. Horowitz whether I need any kind of medication or not. But in speaking to Dr. Horowitz, in a lot of cases, the left side kind of takes over for the right side, and many people don't need it, as far as I know. I don't
Well,
want to
knock
say
on
that.
wood that that's the case. So you're going to be testing her soon then? On
Yeah,
that.
I just got my blood work, so she'll be getting them soon.
Okay.
I'm still interested in the surgery. Was it done what we call laparoscopically, or was
No,
it invasive?
it was invasive.
Okay.
There's a tiny scar.
You look so great. Do you mind if
Sure.
we just show
Yeah.
Because once you
Yeah.
mention
for anyone
it,
who's afraid, that is
Yeah.
amazing, and that's fantastic.
Yeah, it was.
And that's going to fade to nothing.
It will. And, when I went back to Dr. Turner, can I put Mederma on it? Can I do this or do that? And he said, you don't have to do anything except for make sure you put sunscreen on it. Don't get it in the sun for the first year. So I've been lathering up with sunscreen because in the first 3 months, it's going to turn a little red, more red, he said, but then it'll fade even more. Where if you get a sunburn, it's going to really damage the skin that's trying to repair itself. But
and sitting this close to you, I would not have known that was a scar
Yeah.
unless you brought it up and
yeah.
pointed it out to us.
And after the surgery, it was literally a steri strip, and I really didn't know what was under it. Was it stitches? Was it glued? I didn't know what it was. And a week after my surgery, I went to see Dr. Turner, and he just kind of ripped the strip off and said, "Okay." And I'm like, you don't take stitches out. You're not doing anything. But there was nothing really there.
That's great.
Yeah.
So are you on meds for diabetes?
Yes, I have an insulin pump.
Okay. So if hopefully you won't need them, but if you do, then you're going to have to kind of manage that. But if you can manage an insulin,
Yeah.
then you could
Yeah,
manage.
I've been doing it for
some
18 years, so
Synthroid,
it's
right?
second hat now. And again, it's it's the doctor. I see Dr. Horowitz every 3 months, and she keeps me on the right track. And but I know a lot of people that are diabetic that don't. And again, they see doctors that aren't as good as Dr. Horowitz.
Yeah.
So.
So, Danielle, I have to ask you because we've had so many questions about thyroid issues that every time, I don't know how, obviously you're very free talking about it,
Yeah.
right? And so you're kind of living your life and you're an open book and
Yeah.
you're willing to share to
Yeah.
help someone else. People must come out of the woodwork with questions for you.
I don't. They kind of look at me and they're like, "You had something wrong with your thyroid."
Because you seem too young.
Yeah, I mean, I get it now. You have diabetes. You had a stroke, but I mean, I like to talk about it because I want to help people. And if anybody has any questions, like I said, I had no. I mean, there was no. I didn't feel anything. I was perfectly fine. So I can't say, oh yeah, you know, I was tired all the time, or you know, I had the shakes. There was nothing really wrong with me. So as far as talking about like symptoms, I didn't have any when it came to the thyroid.
Even in retrospect, you were asymptomatic?
Yeah.
We have a comment, I believe.
I want to thank you for sharing your story. You know, it's really great to hear, you know, all the success you've had with Dr. Turner and Dr. Horowitz. And I also wanted to mention that you are not the only one in the Dr. Horowitz fan club, I don't think, because we have had a lot of comments on our Facebook feed. We love Dr. Horowitz. She's the best. Her team at Bay West is tuning in, watching. So probably a lot of the folks that you interact with when you go to see her. And someone else says, Kate says, love Dr. Horowitz, you rock. So you are not alone in your love for
So
Dr.
you're being
Horowitz.
treated by a rock star.
Yes, she really is. And Dr. Turner, my interaction with him has just been recent with the surgery, but he was wonderful.
Was he as funny with you as he was when you were sitting here?
Yes. Yes.
I loved his sense of humor.
Yeah. Yes.
We should
Very
say-
dry.
We should say that both doctors are part of GBMC. It's very small print up there, but the letters should be larger.
Yeah.
Is it, and this is, you may know this, and also obviously Dr. Horowitz, does the diabetes heighten the risk of some kind of, no, has not related?
Sorry. This is Dr. Horowitz.
thought you were
In Danielle's situation, she has type 1 diabetes, which is an autoimmune condition. So thyroid disease in general is more common in people who have one autoimmune disease. So hypothyroidism is more common for her rather than nodules, but she happened to have a nodule. But definitely in type 1 diabetes, thyroid is much more common. So that's something that you need to look for. Also, all other autoimmune diseases, that's something I didn't touch on, is that if you have one autoimmune disease, if you have thyroid disease, you have a higher risk for other autoimmune diseases too. Premature ovarian failure, you can have vitiligo, you can have a higher risk for lupus and myasthenia gravis. There's a whole long list of autoimmune conditions that you are at higher risk for if you have autoimmune thyroid disease. And your physician should look for that if you're having a medical condition, sort of put an autoimmune evaluation sort of higher on the list if you're looking at that. So.
I hope you're done with medical
I
complications.
do too.
Yeah, you really.
I do too.
A 4-year-old is challenge enough,
Yes.
you know? Do you have advice for other people who maybe, I don't know, maybe they feel something, maybe they just haven't gotten checked? Any advice? For
Get checked. Get checked.
Yeah.
Be, you know, diligent. Be your own advocate. Make sure you get the blood work. Hey, if insurance doesn't cover it, insurance doesn't cover it. Pay for it yourself. And I'm so much, you know, again, it's your team. It's your medical team. Make sure you have the medical team that listens to you. I mean, my appointments with Dr. Horowitz are probably an hour long because we sit and talk, and she actually listens to me and wants to know, hey, what's going on? Are you feeling this? Are you feeling that? So
Yeah, because you may have some little aside that you'll just say in the course of that hour that will pick up on something.
yes.
Did insurance pay for it for you?
Yes.
Thank you.
Well, Danielle, best of luck to you.
Thank you.
And,
Yes.
Thank you so much for sharing your story. Good luck with your daughter.
Yes.
Good luck with your
Yes.
daughter.
Thank you.
All right.
Thanks.
Take care.
Thanks.
And again, we have still lots more questions yet to be answered, and they will be answered on social media through GBMC, on the Facebook page. And we want to thank all our studio audience. I hope you guys got your questions answered too. We tried to get everybody in.
We hope you won the door prize as well. So that's today's edition of Greater Living. We'll be back next month
Yep.
with another.
In the meantime, take care of your thyroid.
Bye-bye.